several thousand patients and I don't know how many electrograms. And I wanted to move on here to this. Your data is very similar to others that have been presented recently. This is from Healy up at McMaster in Canada. 2,580 patients over the age of 65 with a history of hypertension, no AF history, 8 weeks or less permanent pacemaker ICD implantation. And they interrogated the device for subclinical atrial arrhythmias, defined by greater than 190 minutes beats per minute for 6 minutes within the first 3 months. And this is the incidence of clinical atrial arrhythmias, which is quite high, but what is important is that subclinical atrial tachyarrhythmia shown in yellow over orange were significantly predictive of stroke or systemic embolism. And I think this is a fundamental contribution that may really change the way our clinical practice, and I think the data we've seen today in a much larger population is very supportive of that. Now, these are the concerns. In Olmsted County, Minnesota, on new diagnoses of atrial fibrillation, 35% of our patients were clinically silent, and another 31% had atypical symptoms. And if you look at these data that we published a few years ago of incident stroke cases and controls, shown here is the prevalence of atrial fibrillation, percentage of patients in women and men who had stroke, and those controls without stroke over a period from 1960 to 1990. And you see that 15 to 20% of patients presenting with stroke had atrial fibrillation, and their first clinical presentation was that of stroke. So the questions I have for the investigators, I'm still a little fuzzy about the short and long episodes. Do we know whether we're dealing with seconds, minutes, or hours? Because what is needed, and it's very difficult, it's going to be very difficult to come up with these numbers, but we need an estimate of atrial fibrillation burden. For instance, if you have one episode lasting for 50 hours, does that mean as much as 50 episodes of 1 hour duration each? And these are figures that we really are going to need to try and understand, because there's no question that we will be seeing more and more silent atrial fibrillation as we use these devices in this way. So the potential clinical applications to conclude are this: the identification of atrial fibrillation in patients at high risk of developing AF, would that have an impact upon patient management? So if you take, given the high risk of stroke, given the silent atrial fibrillation, if we detect atrial fibrillation in asymptomatic patients with risk factors, how are we going to manage them? What does that mean? Will it ever be possible to determine the threshold AF burden that warrants anticoagulation? What about if you have 10 episodes lasting 2 hours each over 6 months? Does that warrant long-term anticoagulation? And I think given the 2 neutral trials of PFO closure and stroke, a burning question is how many of these patients actually had cryptogenic stroke due to subclinical silent atrial fibrillation. And in regard to this first clinical application, this is a trial that's going to start in the next month. It uses a very small implantable monitor sponsored by Medtronic. Principal investigator is Dr. Jim Rifle from Columbia. 420 patients who are at high risk for the development of AFib. They will receive this monitor. The purpose is to look at the incidence of silent AFib, identify predictors, characterize the timing and nature of clinical actions following the detection of AFib. The patients will be enrolled, successful reveal implant, and we'll follow them up basically for about 3 years. And I think if we do find that there is a significant incidence of clinically silent atrial fibrillation in these patients with risk factors for AF who are not as sick as the patient population with an ICD or pacemaker, but if we do identify that there is a high incidence, this really may change clinical practice. So it's a very interesting topic, and thank you for the opportunity to discuss it.